So I'm really honored to have been invited to speak here today. I'm also super intimidated by presenting with this audience. But what I'm going to talk about today is analytics at Alberta Health and how we use our administrative data assets. Does this get going on? And how we work with our administrative health data. So to start, I'm just going to talk about who we are at Alberta Health and what analytics does within the department. From there, I'll talk briefly about our administrative data assets. They can be a little bit dry, but I think it would be super useful for this audience as frequent requesters or consumers of our data. I'll move through some project examples. This is probably going to be the most interesting part of the presentation. Obviously, releasing government information is always a little bit complex, so you'll see how that comes through in what I'm able to share today. And finally, I will give some recommendations about working with administrative health data and analytics more broadly in government. And this section could really just as easily be called what I've learned or what I wish I knew earlier. So first, about analytics at Alberta Health. So there are three organizations that report to the Minister of Health. So first is the Department of Health, that's where I work, commonly called the Ministry, but actually the Ministry involves all three organizations. So we also have Alberta Health Services, our very large delivery arm, and the Health Quality Council of Alberta, which does a lot of monitoring and quality. So in the department, we have a few specific responsibilities. These are just 4 of about 7 that are commonly stated. So key responsibility is setting policy and direction and also allocating health funding. These are decision type responsibilities. So in analytics, we're always trying to provide the best available information to support decision makers in making those decisions. The ministry is also responsible for administering programs that it decides to provide and implementing and ensuring compliance with broader government policy. So for those two, we're going to more provide sort of like performance indicators, uptake indicators, just some kind of common statistics that will help support maybe adjustments or changes to regulations. So we're moving towards categorizing analytics into 3 broad groups. The first is descriptive. So here we're trying to make sort of positive statements about what is. So this is things like incidence and prevalence of disease, utilization, immunization coverage, and all we're really doing is reporting, classifying, and aggregating data to do this. It sounds very simple, but this is actually sometimes the most complex work we do just because of the nature of the data that we work with. Moving into predictive analytics, we're using the same type of data, but instead what we're trying to do is identify patterns and relationships in that data and then extrapolate from those relationships to make predictions about the future. So this might be time series, or this might be sort of predictive modeling. Finally, when we move to prescriptive analytics, we're evaluating those predictive outputs in some way that consolidates those measures to inform a direct decision outcome. So I'm going to go through some examples of each of those 3 and kind of how it comes through in our work at Alberta Health. So right here is a screenshot from the Interactive Health Data application. This is a publicly available resource on our public website. So on the far left, you'll see sort of the drop-down menu. So you can go through and select which indicators you want, how you want them cut up, and then they get output in the interface to the right. You can export this to Excel. You can read data notes. Almost no one does this, but you can see our complete methodology here, and it's actually pretty helpful. So here we have a prevalence indicator for COPD, but we also have mental health, health utilization, health cost information, as well as some population projections and other helpful information. So this is sort of a nice way for us to pump our data out into the public domain. It saves us a lot of frequently asked for items, and it frees up a lot of analyst time. And also, it's a great way for us to share data where it should be in the public domain. So here's 2 other descriptive analytic products that we produce. So on the left is a Health Trends Alberta report. These are weekly one-pagers that go out, and usually we try and create them as a byproduct of something that we're already working on. So again, it's a nice way to make sure that the work that we're doing internally gets shared with the public. So if you're not on the listserv for these emails and you would like to be, you can email me. I'll post my email at the end of the presentation. And we post on a variety of things, but it always just includes some sort of graph and a description of what's going on. On the right, you have a screenshot from our annual business report, a very exciting document, which basically says how the ministry is achieving its targets and what we want to do going forward. So this is really supporting planning, and we'll provide the analytic outputs that inform this report. Moving into predictive analytics, so the first kind of most common type would be statistical predictive models. These could be time series forecasting. On the right, you can see a demographic plot that my boss Sean did, and this is population projections for 2020 and 2030. And then we also do a lot of modeling, so this might be decision trees or another kind of similar probability type model, or we use mathematical models, so our mathematicals might be an SIR model for a dynamic SIR model or a agent-based model as well. So here's a couple of other examples of predictive analytic projects. So on the left is a diagram depicting how people flow through the system after making an emergency call and they get triaged and an ambulance is set out. So what we were kind of trying to do is predict what would happen if we were able to redirect the care for those low acuity calls and save resources. So this diagram is not really set up the way we would use it for a predictive analytic project, but it was actually produced by the program area that we were working with, and this becomes a super useful tool if they're able to make this sort of chart and we can communicate with them that way. So that was one project that we've done recently. On the right is a diagram for the pandemic risk assessment model. So this is a dynamic SEIR model. And what we were trying to do is determine what interventions would be the best at preventing or mitigating different types of influenza pandemics. So we had the interventions of immunizing people or treating with antivirals. And this was used to inform the size of the provincial stockpile. Last, we have prescriptive analytics. So what we're trying to do is pull together all those outputs from the predictive model and consolidate them in some way. So cost effectiveness analysis is a really great example of this. Some recent, not so recent maybe, ones that we've completed have been HPV vaccine for boys, shingles vaccine, and we're currently working on a hand hygiene model to simulate how hand hygiene interventions can prevent the spread of MRSA within healthcare facilities. So on the right, you see an image. This is the announcement for the HPV for Boys program, and this is one of the first times that government acknowledged that its decision was made based upon predictive analytic outputs. So that was a kind of cool moment. We also make a lot of decision tools. So these aren't quite cost effectiveness analyses, and we're not outputting an ICER, but they will kind of rank order and apply some sort of decision criteria to outcomes that will help inform decision makers as well. So now I'm going to talk about the administrative data assets that we have. And before I do this, I just want to preface it by saying we really work to protect privacy. We are handling super sensitive data. So individual privacy is always sort of the first thing that we protect when we're looking at this. But we have the Health Information Act, which governs our use and access of data within the ministry. So we can use our data for research, planning, policy development, or quality improvement projects. You can see, based on what I showed earlier, how this would all really tie in to the work we're doing anyway. So there are not a lot of issues with data access internally. Researchers can also access data for any of the purposes listed, provided they submit an application and have ethics approval. So this is a slide from my boss's boss, Larry, and it's a depiction of some of the data assets we have, not even all of them. Some of the ones we use most frequently would be the inpatient ambulatory care data. That also includes our emergency services data and our fee-for-service data sets like physician billings. These cover from 1998 to current. So we have about 20 years of data, individual level observations, and we also have costing for most of it. So for inpatient events, we get case costing for 50% of discharges. In ambulatory care, we get case costing for 30% of discharges. We can then apply we can use a certain methodology where you use case mix groupers and resource intensity weights, and that will allow us to estimate the cost for the remainder of those visits. So we actually have very granular information about everything that's happening there. Some other data assets that I use frequently are the lab test results, and the diagnostic imaging data is new online, but also a really valuable asset. So for the lab test results, we can see what was ordered and actually the result of that test. Pharmaceutical Information Network and Alberta Blue Cross both contain dispensation data at a line level. So you can see who was dispensed, what did, when, and there is a little bit of crossover between those two. And for the Alberta Blue Cross data, we also have cost. Vital statistics information is really important just for knowing who's entered and exited the province. We also have our survey data. So we have the Alberta Community Health Survey that gives us line-level observations where people respond to questions about their current health state. So we have EQ5D responses. We also have information about their health behaviors and preferences in that data. And we have a similar data set from Stats Canada, which is the CCHS. So if respondents consent, we can link that to all of our other data. We also have some important non-health data that helps us link everything else that we have. So on the far left side, we have our central stakeholder registry. So it sounds super boring, but it's basically a listing of who registers with the Alberta Healthcare Insurance Plan and what sort of coverage they have. So we can kind of get some good socioeconomic information out of that as well. So the central stakeholder registry will also allow us to identify uniquely if someone's PHN has changed and reconcile those records, but we're tracking the same person throughout time. Provider registries give us information about who is providing services, what their credentials are, and when they've received them. And delivery site registries let us know how facilities are classified and when they came online. So the key thing to take away there is that we have a lot of data. That wasn't even the full picture of it, but there's actually a lot of data about the health system in Alberta that isn't captured in Alberta Health. It might sit with Alberta Health Services. It might sit in sort of clinical databases or trial databases. So there are always a few gaps, but what we have in the ministry is really quite comprehensive. This data is linkable, and the databases span at least 20 years, so we can really do a lot with it. And the most interesting thing that we can do is manipulate this data and transform it to generate new resources. So a couple of ways that we transform our data. First, we might transform our relational data sets into analytic data sets. So sometimes data, for example, inpatient data might be stored in 12 separate tables. So we might have for one record information about their diagnostic codes in one table, their socioeconomic background in another table, procedures they received in another table. So what we do is we actually join these tables, and it makes it a lot easier to analyze. We also will add in some common flags, like whether or not they came in through an emergency. And I realize this sounds very simple, but most jurisdictions do not do this, and it really slows down everyone's analytic ability. We also do something called creating registries. So what we might do is apply a case definition to many of the databases in our warehouse and identify people with a given chronic disease. And then we'll store this as a registry so that we don't have to apply that algorithm every time. And the data will be stored in such a way that I'll show you in just a moment where you can apply it to a lot of different data sets really quickly. We also have our cost registry. So here we have an indicator of whether or not someone was in the province or not at a given time, and their total ambulatory inpatient emergency and physician costs for that time span. We'll do the same thing for Charleston indexes and our postal code translator file, which we actually disseminate very broadly. We'll map certain postal codes up to larger geographies that you can really look at your data, lots of different aggregations. So it's a little bit easier to show you what this looks like. So this is what a registry might be structured like, and this is something I'd encourage you to do with your data assets, especially if you're working internally with the ministry and accessing some of the stuff that we have. So on the far left-hand side, we have ULEs. This is simulated data. I'm not actually showing you people's healthcare records right now. You can tell because they're 4 digits. Normally, those would be 9 digits. So in the first columns, you have diagnostic, or the first date and the last date from that administrative case definition for diabetes. So coupled with date of birth and age, you can actually do any sort of incidence prevalence calculation. That's a really basic thing you can do, but more importantly, you can link this to other data sets to give you more information about comorbidities very quickly. We also have our cost registry kind of mock-up here where you can see an indicator if someone was in or outside of the province in a given time and their total cost for different sort of cost items. And finally, a Charleston index, which you might also calculate for different time periods. So now this is probably the most interesting part of the presentation. I'll talk about 2 projects. One is going to be super familiar for economists. The other is sort of a more government analytic type thing. So the first one is a project where we're trying to estimate the incremental cost of nosocomial MRSA infection. So MRSA is a bacteria that's resistant to antibiotics. A lot of people get it. It either extends your inpatient stay or is thought to, and it also causes a lot of unnecessary mortality in hospital. So in this project, we're evaluating hand hygiene interventions We're using an agent-based model to simulate the way people move throughout hospital wards. But in order to evaluate the cost effectiveness, we really need a good estimate of the incremental cost for the length of stay. So that's what I'm going to talk about right now. Hospital-acquired infections are a little bit funny. They're exposed to something called time-dependent bias. So because an infection with MRSA can occur at any point during the stay, the way that our costs are aggregated, we'll kind of assume that it applies to the whole stay. So costs related to MRSA will really, in reality, only start being generated after the infection, but we can't really parse that out from our data. MRSA is also associated, we shouldn't say leads, that was the typo. It's associated with extended inpatient stays because those people are probably more prone to staying longer, but they also might stay additionally long. So if your methods don't control for time-dependent bias, we will always overestimate the incremental cost of stay and the length of stay. Unfortunately, our data doesn't actually allow us, or it didn't allow us, to view daily inpatient costs figures. So we have kind of a few method options. The first was to use matching methods for cost and length of stay, or we could apply regression models on the stay or cost separately, or we could somehow acquire some sort of daily estimate of cost. So this is what the data looks like. So the data came from COGSERT, which is an asset that is held actually outside of Alberta Health at AHS, so we had to get ethics to bring it in. Cases could be either infected with MRSA or colonized. They had to be linkable to our inpatient data, and then we also had to have complete costing for these people because we didn't want to use estimated costs in this analysis. So today I'm just going to talk about this circled value here, which are those who have hospital-acquired MRSA infections. So we only have 39 observations. This was only 2 hospitals that we were looking at. So this is what the match cohort looked like. We matched on age group, gender, urban type, which include homelessness, comorbidity, number of procedures, and the facility that they were in. So we did this matching. We have a randomizing algorithm, runs it 10 times, pool the estimates. And the idea here is that if those factors all control well enough for other factors contributing to cost and length of stay, that the difference in means between the cases and controls could be fully attributed to MRSA. There's 2 sort of problems with matching approaches in general. One is that we're assuming that all of our control variables actually control for those 2 outcomes completely in the absence of the condition. Doesn't always hold. And second, any attempts to increase the number of variables that you're matching on will actually select pieces out of the study. So matching, it's easy to implement, it's quite accessible, it's easy to understand, but it doesn't necessarily work that well. So I would be pretty cautious about interpreting the difference in means here as the attributable cost and length of stay for MRSA. So then we moved on to regression methods. So here we can use the GLM or a semi-log OLS, and here we use the NOAHE and NOAHE algorithm to sort of choose between the 2 methods. In doing this, you're comparing the log kurtosis of the errors, you're doing tests for family fit. In all those tests, we did find that gamma log might perform best. So it's kind of nice. We don't have to do any smearing retransformations. We can just sort of interpret our outputs. So we used, to estimate LOS, we used 6 case categories: comorbidity, age, gender, and the number of procedures in hospital. On the right, you see our coefficient plot. Keep in mind that this is on log scale. So we could see that the model was finding that hospital-acquired MRSA really did increase the length of stay. And then to actually get our estimates out of the model, we used recycled predictions. Next, we had the same thing for cost. So these methods are probably performing a lot better since we're controlling for all those confounding factors at the design stage, at the analytic stage, rather than at the design stage. But we're still completely confounded by time-dependent bias. So in using these estimates, we have to be pretty cautious. Other studies have found that failure to account for time-dependent bias results in an overestimation of cost by about 31%. So last month, we actually gained access to daily inpatient costs. This is a totally new data asset for Alberta Health. So this was my first time working with it, and it's really cool. So here, this won't be our final method, but we actually have daily costs for 39 cases. Actually, in this set, it was only 29 because of the window for which we got those daily costs. So 29 cases, our daily costs centered around a concurrent community where day 0 is. And then we matched based on the idea on all the same factors, but also including they had to be in a facility for at least as long as the cases. So the idea here would be that the space between the two lines, accounting for the standard errors, would be the incremental cost of MRSA. That said, I don't actually think this is the best way to do it, although it's sort of a nice way to visualize it. What we'll probably do is a panel regression with fixed events. So that was pretty familiar with a familiar sort of approach for this audience, I think. This next project is a little bit more targeted towards government and sort of how we approach problems internally. So Alberta Health has always had a strong interest in approaching problems related to need and access to health services. This isn't a new concept. I promise you, it's not the first time we started thinking about this. But we were kind of invited to give some analytic support for this. So some other activities that would be going on in the ministry would be process mapping, priority setting, developing better the interface between Alberta Health, Alberta Infrastructure, and AHS, and finally we were starting to develop analytics. So when we're thinking about need for and access to services, there's sort of 3 entry points where we might be invited to support analytically. The first is to respond to community advocacy. Second would be proactive internal planning. And third is a review of capital infrastructure and its use. So I'll unpack these with some examples. So first, our analytic approach was to provide a suite of tools that could be used across the 3 purposes or entry points, keeping in mind that those are distinct enough that they can't all be met with one tool. We wanted to make sure the tools that were simple, easy to use and interpret. We wanted to be able to hand these off to the policy and program areas so that they could actually interact with them, use them, and make decisions based on them. And we wanted to use common measures across the tools so that they would promote consistency across the use of the tools, but also consistency in how we approach different local areas and geographies and communities. So first, an example of responding to community advocacy could be the minister meeting with officials from the community or a constituent writing to request increased services in their community. So in either way, the ministry must take action or must respond in some way. So to support that, we wanted to provide a tool that would measure key indicators, which we selected in partnership with the program areas that are most involved with this, to compare need for and access to services across all communities, so comparing all communities in Alberta to each other, or just within rural types or urban types, and so on and so forth. So this is what we call the need assessment tool, and I've had to sort of truncate the view, but normally on the left-hand side, we would have all of the different communities by name, their type of jurisdiction, so if it's a rural community, a metro community, and we also have a bunch of sociodemographic indicators about those communities. So what you can see here are our age demographics, and then the distance traveled, the proportion we're traveling different distances to access different healthcare services. So here we have a GP, emergency services, and hemodialysis. This goes on for about 10 indicators, and at the very back, it's a very wide table. We have some chronic disease indicators as well. Oh, and I should say, the color coding is dark if it's a higher proportion. This is based on standard score, so this will account for the size of the population in whichever community we're talking about. There's 132 communities at this geographic resolution, and we do this by using a blue gradient scale rather than a green to red color scale, because the interpretation gets a little confused when people see bad, good. These are proportions that might have different interpretations for different things. And this is the kind of thing that we really think about hard when we're translating information to community to our program colleagues, because we want to make these tools as accessible as possible. So an example of how this is used, the minister will be meeting with the mayor of a small town, I have to change the names here, and other officials to discuss the condition and capacity of the community hospital. So we can say compared to other rural communities, so comparing this community to others like it, that they have good access to some services, average access to others, and poor access to a few. So that's pretty straightforward. It gets used all the time. It obviously saves everyone a ton of time. We're not re-pulling data every time some emergency arises. but it doesn't really help us plan. So the next entry point would be Alberta Health One to identify communities with low access to services, or identify communities that have really high needs. Keeping in mind that high needs might be met with great access, but we just want to sort of identify both of those two things separately. So we built upon the measures in the need assessment tool. So this is how we're kind of keeping the tools integrated with each other to develop a tool that applies criteria to rank communities by both access and need. And I should say these tools are all built in Excel. We really like Excel because we can send it to our colleagues very easily. You can make it look nice. And they can also look in the back end if they want to and really understand how things are working. And if you're afraid of them doing that, you can just hide the sheet. So this is the ranking tool. So the first thing we did was split out need for services and access to services. So these are all the indicators from the need assessment tool. So we have indicators like what proportion of the population is aged over 70, who's eligible for ICACP, which is sort of a high acuity service that we can give to certain Albertans, and chronic diseases. So with each of these, users can go in and weight the importance of each of those. All of the indicators in the background have been normalized so that we can rank and consolidate them really easily. So once that's done, if you're just looking at need for services, the top 5 best communities and worst communities would be populated in the table. I've had to mark it out. Similarly, for access to services, you can weight the importance of these different services relative to each other. And we actually have thresholds about how far we believe people should have to travel for a given type of service. So, for example, it might be more acceptable that someone in a rural remote community would travel 300 kilometers to access primary care, but we might not really think that's acceptable for people living in metro centers. So decision makers can be explicit about their preferences and receive rankings based on those. So for example, if Alberta Health would like to allocate resources to benefit a community with poor access, they would apply criteria, and we would identify the fictional Fort Hills as our poor access community. And third, this is sort of the most interesting tool, I think. And this is actually where we started, and it's kind of, I can come back to this in the recommendations, but we thought they wanted the world, and it turned out they wanted a spreadsheet, which was the needs assessment tool. But this was our solution to sort of understanding where, how the government should plan, how the ministry should plan, where to increase capacity in the system. So say capital planning, which is a branch internal to Alberta Health, wants to increase capacity for a given service and must choose only 2 communities to increase capacity in. The goal would be to maximize benefits for all Albertans. So we're not just trying to optimize care within a community, we're thinking about who external to that community would dynamically change their behavior and start going there. So we developed a model that simulates scenarios to determine the optimal service allocation under a set of criteria that decision makers also have to make explicit. So we actually made 2 versions of this tool because there's sort of 2 lenses from which they might approach the problem. So here we have a type of service. So for example, pacemaker insertion. So they might prioritize one of 4 optimization criteria. The first is a change in distance traveled. So we're just saying we want to minimize how far people have to go. We're going to rank these normalized scores based on that. Second is the change in service allocation. So this is more a measure of how many people are impacted by this allocation change. Finally, the population of the new community. So putting a well-located service in a community that has a very small population may just not make sense. And finally, if your allocation would be really good, but we'd only be doing about 5 additional services, it wouldn't really make sense. So decision makers can input these criteria and threshold, and we'll output the best community pairs and the worst community pairs. Here too, you can see that we could look at 2 services simultaneously here, so we can check pacemaker insertion in combination with cataract surgery, weird combination, but you can do it. Sure.
Yeah, I just wonder what algorithm are you using for the maximization?
So to do the simulation or the maximization?
Yeah, your maximization for not to maximize something or minimize something. You have to put some mathematical calculation or some algorithm compare. I don't know which way you use.
So we simulate all the different community combinations. So we have outcomes, and the change in all of these outcome measures that are listed here.
Or you compare each other.
Yeah, and then we normalize those, rank them, and combine them to get the score. Does that answer your question?
Yeah.
Okay. Yeah, so we'll have our community pairs listed, and these will actually be spelled out as community names. Again, I've had to remove them, but this criteria might not make a lot of sense anyway. So this is a slightly different view of the same optimization output. Here we know that there are certain assets that already exist in the province. There are certain places where it may make more sense to sort of build resources. So you might have a couple community pairs in mind to start with. So here, decision makers, whoever wants to use this tool, can drop down pairs of communities from these menus and compare them. So if you want to compare community pair A to community pair B, this indicator, which says better very clearly, will actually move to indicate whichever community is better. And in the same way, you can change your criteria at the bottom. So the Alberta Health wanted to create capacity for pacemaker insertion into communities in such a way that overall travel distances were reduced, and we would identify a northeast rural community and a southwest urban center as the optimal pair. And so this actually, it really checks out. It has a lot of face validity because the results that we were getting did really demonstrate a need in certain populations, and you could see geographically why these results were making a lot of sense. So in summary, we wanted to provide analytic tools to support reactive and proactive initiatives related to health service need and access, and we also want to promote efficiency and consistency. So whenever we're trying to produce these outputs, we want to give something to program areas that they can use so that we can move on to other things, but we also want to do it in such a way that they'll be consistent over time. We can check back in with them and also maintain the tools. So both of these projects center around resource allocation, either avoiding unnecessary care or assessing the optimal allocation of future care. So although economics isn't really explicit in the analytics and performance reporting branch, I think you can see how it sort of fits in, especially in the predictive and prescriptive analytic domains. Okay. So some recommendations, or what I wish I learned a lot earlier. So first, if you're extracting data, you're probably going to be accessing data from massive data sets. Inpatient data covers 20 years, it's 400 columns wide. This data gets uploaded every month, and when data gets that big, weird things happen. So you might write perfect extract code, but there might be some weird things in your variables. Because of the way the data is submitted, the two things I like to check are time. So for every variable, how does it vary over time? Are there dropouts? And if there's not dropouts, are there missing values that look like populated values? Or did the codes change? So if you kind of look at the distribution of frequencies that you're getting for different variables over time, you can kind of catch a lot of those things. So I check by year and also facility for those types of issues. I also evaluate derived variables. So I showed you those registries that we made. We have disease registries for almost all chronic diseases merged onto one table, so it's really easy to link. And we've kind of chosen those based on what we believe to perform the best. But I wouldn't want someone to come into the ministry and think that they should always use that case definition that way. It makes sense for a lot of the work we do, but we don't know your purpose, and you should evaluate the case definition for your purpose. So if you're not using something off the shelf, which I don't recommend all the time, I would test the inputs to make sure your algorithm is performing appropriately. The best way to do this is spot check the subgroups. So if you have people who are meeting a case definition and not meeting a case definition, pull some of those records, look at what's happening, and make sure that it kind of follows the logic of what you're trying to apply. And just really check the logic of your algorithm. I've seen a lot of really good work derailed by a greater than or less than sign in the wrong direction. So once you have your data and you're confident about it, I'd encourage you to really think about the methods that you're using. And because of the way our data is stored and our data environment, you are not restricted the same way that people are in a lot of other jurisdictions. So a lot of the way studies are designed, say in the US especially, they're designed in such a way that they have to be because of the limitations of their data. So before you simply adopt the methods that have been used elsewhere, think about if you could do better because of the data that we have. And actually, it's a great way to make the contribution to actually compare methods. And so if you can use better methods, also do the poor ones so you can tell other people about it. I would say check your methods on simulated data. So the Manning and NOAHE algorithm that we used for the MRSA incremental cost, it's a really common one that we would use often to determine the best model to estimate incremental healthcare costs for a lot of purposes. So to make sure that we're implementing the algorithm the right way, we actually simulated data, tested the algorithm, made sure it was performing the right way, and now we have that algorithm neatly stored so we can just pull it off the shelf when we want to and test on the data. So I'd say simulate the data, document it, and then write yourself a tidy program to make sure you're not going to mess up on the methods going forward. A lot of people work in Stata. At the ministry, we work in SAS. Nothing is exactly the same, so it's something that you want to really validate before you sort of proceed with your analysis. I'd also say discuss with clinicians. I'm not recommending that they make an expert opinion for things. What I'm trying to say is that if you see something in your data and it looks a little weird, some kind of care sequences are off, or people seem to be receiving something that you wouldn't expect them to from the data, I would check in with clinicians. They often have a really valuable perspective on why things might happen. They'll recommend you check things that you haven't, and if you can in your project, you can always sort of have someone that you can talk to about that sort of thing. Dissemination. First, and this is probably the thing that's been the hardest for me to learn, is verify what outcome is desired from the analysis. So in government, unfortunately, you're getting a lot of projects from people several pay grades above you, and you can't really pepper them with too many questions about what they want. So sometimes you don't find out you've done the wrong thing until you've gone far enough down the path that you've produced something completely. But usually what they want is actually a lot simpler, so you can kind of backtrack and they're still happy. So I'd say what some of the best advice I received is actually from Martin Meltzer, who spoke in the series last year. And what he likes to do is he asks his sort of client groups to populate a decision or like an outcome table that they want to have. And if you're having that conversation, or you have them at the stage where they're producing a flow diagram of their process, you're probably communicating really well. This is one of the really key things to nail down. I really like to build interactive tools. I do this for a couple of reasons. One is because that can kind of allow people to become self-sufficient and produce their own results when they need them. But the other thing is that if you've built an interactive tool and you have someone using it, they're really buying into it. So people won't make decisions on information that they're not comfortable with. And then the utility of your analysis is completely gone. So if you can give them something that they believe that they can test and they can use, your work won't go to waste. Finally, and this is probably mostly a government-targeted recommendation, but it's to state your output extremely clearly. In a forum like this, where I can just speak and I don't get interrupted too often, I can really state what I want to state. Or if you're writing a paper, you can state your assumptions and your recommendations very clearly. At higher level tables with decision makers, you may only have about 10 minutes, and those 10 minutes can very quickly be taken away from you. That means that anything you said could be quickly misinterpreted and goes into some sort of process where it's happening. People are making a decision based on not what you said because they misinterpreted it. It's always in your best interest to correct them, but it can be kind of career limiting. So whatever you do, put it super clearly so that there's really no space to misinterpret the results. So that's all I have. Thanks. I hope people have questions.